Okay, everybody, we are so glad that you are here with us today. Welcome to the LIP Collaborative webinar, and we're going to get started. Just a few odds and ends about the webinar. I'm Roanna Newton, the Provider Network Account Specialist. I'm your moderator today. We do have some wonderful presenters for you. I just want to remind you that the audience is in listen-only mode. You can only hear us talking, but you can't talk with us through the phone in an interactive way. You can submit any questions that you might have from today's webinar to questions@partnersbhm.org, and we will respond to you. Also, we want to make sure, as a reminder, that you all are remembering the NC Health Connect requirement by the state. This means that all providers must be enrolled or have a state-approved extension by June 1st, 2019. And this is very serious because if you do not, you won't get paid. Handouts with information pertaining to NC Health Connect will be uploaded to the Partners BHM webpage under the Webinar tab, and links for the provider webinar can be found at that link below. So you can follow that after the webinar. We do post the webinars on our website, so you can see those later. I also want to remind our ACORN tool providers to please make sure that you're reading your ACORN contract agreement. These agreements will appear in your performance monitoring tool, and Lisa Jordan is going to be talking about that a little bit later. But these requirements are in your contract, and the expectations that you need to be aware of are really important. So we want to make sure that that's a reminder for you guys to be paying attention to that. Also, for our ACORN tool providers, please make sure that you are not faxing your ACORN surveys into clinical informatics. This incurs an additional cost to Partners BHM, which is above and beyond our contracted agreement with clinical informatics. So we will not continue to pay that additional cost. Any providers that continue to fax surveys will be financially responsible for the costs associated with informatics processing fees. So make sure you're paying attention to that and not submitting them processed that way. Okay, so we had a request, the last collaborative, to do a survey, and this was a really great idea because we wanted to make sure that people were looking at electronic health records. So we did a little survey. We didn't have a lot of response. Only 10 people completed the survey. What we found is that only 2 participants, or 20%, already have an EHR. 80% do not. The 2 chosen EHRs are Valent and Valent Med. 33% of the LIPs want the EHR to be user-friendly, easy to implement, and have reasonable costs, which makes sense. And challenges associated with the EHR for those that did implement were transitioning from paper to digital, the time involved to do that, and learning the billing piece, finding a good workflow for the digital pieces, and transitioning to new forms or trying to implement Medicaid-approved ones to ensure that there were no difficulties for monitoring. So we really appreciate the providers that took the time out to do that survey for us. We really appreciate that. I know that was something extra that we asked for you guys to do, and we really appreciate that. And so now I'm going to turn it over to Beth Lackey, and we're going to hear about what's going on with the 1115 waiver. So Beth, what's going on with that?
Good morning, or good afternoon, rather. Thanks for attending our LIP Collaborative. So a couple of things that, well, actually more than a couple. I wanted to give you all an update on the 1115 waiver status. CMS did approve North Carolina's submission for the 1115 demonstration. That approval came through October 24th. 2018, and it would be effective for January 1st, 2019 through October 31st, 2024. And so the state has worked very collaboratively on that transition and Medicaid transformation. So just as some of you may have seen this information, it is on the division's website. In August, an RFP for Medicaid managed care prepaid health plans, that's a fancy way of saying the physical health side of Medicaid, was released. And inside of this RFP, they are asking for health plans to make application on providing what they're referring to as the standard plans. EHHS will oversee all aspects of the Medicaid and NC Health Choice program, but these prepaid health plans will directly manage certain health services, assume financial risk, and contract with providers. And that's what we know as the standard plan. It is the largest procurement in DHHS history. All plans are going to be subject to rigorous oversight and monitoring by the state. And so that process for that request for proposals was released in August. And fundamentally, the waiver provides North Carolina with the ability to implement Medicaid managed care and to phase certain populations into that over time. And that's the purpose of the ability for that to occur, and that ties into the flexibility inside of the 1115 waiver. So what are the goals of the 1115 waiver? That you would have behavioral health integration, tailored plans, specialized health homes, that there is an opioid strategy component to this, and then there are healthy opportunity pilots. And I'm going to talk a little bit about those three goals in the next few slides, but I did want to provide you the PDF document that gives some information on that. So what does it mean for behavioral health integration and tailored plans? So North Carolina will integrate physical, behavioral, and pharmacy benefits with both standard and tailored plans. And that will involve various populations, benefits for those with SMI, SED, severe substance use, IBD, or traumatic brain injury inside of the tailored plans. There are going to be specific sets of behavioral health services inside of the tailored plans that the standard plans would not be responsible for. And so the impact is this is the way to coordinate better care, to have integration of physical and behavioral health. And so you kind of have the ability to have the standard plans that many of our LIPs may be working with, and then the tailored plans would be more for the more significant population, as I just mentioned. The second piece of the overall strategy is an opioid strategy to combat our opioid crisis. There is a desire inside of these transformation goals of the 1115 to increase access to inpatient and residential substance treatment by beginning to reimburse for those services that are provided in an institution of mental disease, expand substance use service array to ensure that the state provides the full continuum of services. We believe that this gives the ability to strengthen the quality of care and outcomes for patients or clients with substance use disorder and decreasing long-term use of opioids. We want to increase utilization of medication-assisted treatment services, which is the best practice, evidence-based practice for the population. The third transformational goal is a healthy opportunity pilot. These are going to be implemented inside of the Medicaid managed care program in 2 to 4 regions to improve health and reduce healthcare costs. they are looking to identify areas to focus on social determinants of health. And how do we care for people that includes all of the things that a person needs as opposed to just their behavioral health needs? And so they're going to, as part of this system transformation, look for opportunities within the standard plans or in conjunction with the tailored and standard plans to build healthier communities so that we can increase the health of North Carolina. So what's truly the goal? The RFP gives standard benefit plans which will provide integrated physical health, behavioral health, and pharmacy services. Medicaid and NC Health Choice recipients or beneficiaries with a lower intensity of behavioral health needs. So these are people that are in your outpatient clinic setting. They have maybe some physical health conditions and behavioral health conditions, but they're not receiving an enhanced benefit service that we call it in our mental health service array. So beginning in 2021, most individuals with a serious mental illness or serious emotional disturbance, etc., would be involved with a tailored plan. And the BH-IDD tailored plans will be procured through a separate process. So that right now will be the LME MCOs that will be partners, being one of the tailored plans, and that will be a separate process. So the first wave is around the physical health, lower intensity services that they are going to procure the contract for Medicaid transformation. One of the goals is that they want to ensure that these new standard plans that are coming in have strong networks. There are specific standards around network adequacy, around coverage of out-of-network services. These plans, just like the LME MCOs, will have network adequacy standards and analyses that will have to go on so that they're able to fill their gaps, look at the needs of the regions that they're responsible for, to make sure that the members, the Medicaid members, NC Health Choice and Medicaid, have access to the services that are needed. So what are the next steps? The RFP was released in August and it closed October 19th. They will review offers to determine that they kind of go through the process of any RFP. They have a selection and screening process and evaluation committee to evaluate the proposals that are meeting the minimum qualification, and then they will submit the contracts to CMS for its approval. And the trajectory of the plan currently is that these contract awards are anticipated to be announced in February of 2019. That the health plans that did submit RFPs to the state for review were 8. And those are on this slide that you have before you: Aetna, AmeriHealth, Caritas, North Carolina, Blue Cross Blue Shield, or Healthy Blue, Carolina Complete Health, My Health by Health Providers, Optima Health, United Healthcare, and WellCare Health Plans. So you have that information. This is all public information on DHHS's website, which we've included the link throughout this presentation, and they are doing a really good job of putting the webinars and the sessions and the information about Medicaid transformation on the division's website. All right, so what's our anticipated time frame? Now and ongoing, we've got February 2019 that the state will award these contracts to the selected health plans. In the summer of 2019, these health plans must have contracted with enough providers for their network to meet DHHS standards. July 2019, they have to have call centers operational with relevant staff set up. July to September is when this Medicaid managed care is going to start in 2 phases, and it's going to be regionally based. So phase 1 will be in one region of the state, and then there'll be a second region of the state for phase 2. And so you can see that this is going to be an ongoing process through 2019 into February of 2020. One of the things that the RFP required was that provider payments would be, that the provider payments would not be disrupted, that they would comply with department established rate floors for in-network providers, that they can mutually agree on different rates with the providers that they're contracting with, and that the department will monitor those provider contracts that these standard plans engage with providers to determine if rate ceilings need to be established. So this will be all part of the process of the contracting process within the standard plans. As we, as LME MCOs, have these prepaid health plans, standard plans have prompt pay requirements just like we have. Out-of-network services must be included just as the LME MCOs have, and then making sure that there are emergency or post-stabilization services available inside of the standard plan. So what are the rumors about Medicaid managed care? So you may have heard that providers must sign a contract now to continue serving Medicaid patients in the future. That's false. So what has to happen is once the bids for these RFPs go through, then these PHPs must contract with the state. They must be licensed by the state. They have to have their provider manuals, contracts, and contracting policies approved by DHHS, and Medicaid fee-for-service program will remain operational to serve these excluded populations. So before these contracts are awarded, there is a pre-award period where you may be already discussing with health plans that they want to include you in their network. You may already be in some of these networks. And so making sure that if you are communicating with the health plans about the outpatient services that you deliver, that you are having that conversation and that you are, meeting with them to understand those expectations. So what's Partners' vision and the 1115 waiver transition? So we believe that we want to have good collaboration. We want to deliver quality care. We want to maintain collaboration. We want to enhance our collaboration at all levels of the system to make sure that we are part of helping this transition move forward. And then we want to be able to train you all and focus on outcomes and focus on those things that are going to help you as providers be successful in this transformation. So a couple of things that we're working on is that we believe that part of the components of having key components in this transformation is looking at value-based payment, looking at the population health. So the Healthy Opportunities discussion earlier about transformation ties into how are you treating a particular population in a continuum, and then making sure that there's innovation around whole person integrated care, that evidence-based practices are being utilized. You're utilizing potentially the feedback-informed treatment that the ACORN provides you, that there is a component of collaborative care, but more important to that the standard plans are going to be partnering with a tailored plan. And so Partners is engaged in that process. So in thinking about your LIP practice or your group practice, looking at your own organizational assessment, your strengths and gaps, how do you evaluate who you want to work with the standard plans, and then what is your value add? You have something to offer to the standard plans. You have been serving the Medicaid behavioral health population, and so you need to think through what are the things that you find in your patient population that works well, that you've seen good outcomes, and that show and demonstrate that they're getting better. When you look at population health for behavioral health, you can see that screening, health promotion, early intervention, prevention, mild to moderate behavioral health needs are going to be inside the standard plans. Inside of this transition, you're going to have some overlap. As you see, it moves up the triangle. And then at the top is a more concentrated complex needs population management of specialty behavioral health services. I did provide for you an organizational assessment. It may not apply to you as LIPs. It may. You may just be curious. This is what are the things that you need to think about in moving towards an 1115 environment, and we've included the PDF assessment for you to review. So we have a CEO roundtable regarding 1115 waiver planning. This connects directly with our provider council. So those of you who are members of our provider council then are getting this information on a monthly basis. We have large and small providers across disabilities. And then we want to make sure that we have the stakeholder input around the 1115. And that's how we wanted to integrate this information into our LIP collaborative.
Great, thanks, Beth. We really appreciate that. Now we're going to transition over to our credentialing update. Fielding, what can you tell us about credentialing?
Good afternoon, everybody. I am going to try to keep my comments rather brief today. I'm kind of just going over some of the frequently asked questions and some of the main points that can cause some confusion. So the first matter is the CAQH information. All applicants must ensure that their CAQH information is up to date. You must complete and upload a state release authorization form. That's a CAQH form with partner's name on it. To CAQH. The form can be found in CAQH once we roster you. So once you receive a notification from credentialing staff that you can go and get that form, please do so as quickly as possible so that we can get that information and process your application. We receive a number of questions that fall into two categories after CAQH, which will be the focus of the remainder of this presentation, and that is insurance questions and questions about National Plan and Provider Enumeration System, which is more frequently known by its abbreviation of NPIS. As to insurance requirements, partners must be the certificate holder on all required insurance policies. It is not necessary for partners to be listed as an additional insured on these policies for LIPs. So we must be a certificate holder. That's the important take home. We do not need to be the additional insured for LIPs. Continuation of the insurance requirements. You must complete the partner's behavioral health management insurance affidavit for contracted providers form if 1, you do not transport consumers. This is a waiver of the automobile coverage. 2, your number of employees exempts you from the requirement of carrying workers' compensation coverage. That would be the workers' compensation waiver. 3, You rent your office space and your landlord holds the general liability policy covering the property. That's the general liability coverage waiver. Please note, though, you must be able to produce a copy of this COI. The slide says policy or certificate of insurance. We really need the COI, not the whole policy, which can be, but you must be able to produce a copy of the COI. This policy is not held by the applicant. The coverage limits do not apply. The 1 million and 3 million for the general liability do not apply if your landlord is the covered person. You can obtain this form by contacting Partners Credentialing Department at credentialingteam@partnersbhm.org or 704-842-6483, and these slides again will be posted so you can get that contact information from the web page. Again, this information, just to kind of sum up, has to do with the affidavit of the Partners Behavioral Health Management Insurance Affidavit. You might not have any of these waivers or need any of these waivers, but provided you have one of those three, the transportation, the workers' compensation, and or the general liability, then you would need to fill out this form. For INPES, addresses, taxonomies, and NPI numbers must all match in NCTRAC, INPES, and ALPHA. Inconsistencies among these databases will not stop your credentialing application from being processed, but they will stop you from being able to bill. So they need to be cleared up as quickly as possible to get paid. Might not hold up your credentialing, but it will hold up your billing, so bear that in mind. Practices with multiple site addresses. Partner staff can only see the first site address in INPES. If you have multiple sites, multiple addresses associated with an NPI number, we can only see the first one. So you will need to print screenshots for all other site addresses and submit them along with your application material. Continuing on with INPES, in order to make changes to your information, for individual changes, or for individual NPI numbers, you'll need to call 800-465-203 and ask for a roll request to gain access to your NPI information. For organization NPI numbers, you'll need to call 866-484-8049. Then you'll select the option called Identity and Access, or INA. Ask for guidance in processing a roll request to gain access to your organization NPI information. For all changes related to the organization NPI, you will likely need to have your W-9 handy when you call. Partners cannot process your credentialing application until your current practice site address associated with your organizational NPI is entered into INPES. And again, those are some of the frequently asked questions that we get. I just wanted to address those again for you. And again, this will be posted to the website, so you can refer to it whenever you need it. If you have any other questions, please feel free to call the credentialing line, email the credentialing team, and we will be more than happy to assist you in any way we can. So have a great rest of your day.
Thank you, Fielding. We appreciate that update. Now we're going to ask what is in your compliance toolbox. And Mike is going to talk to you from Program Integrity.
Good afternoon, everyone. Just want to take a little bit of time to briefly go over some suggestions, some things to be aware of in developing your compliance toolbox if you don't already have one, and also some other maybe some other ideas that you can incorporate within your compliance program, respectively. Just a little bit about us. Our mission in regards to program integrity, as you may be aware of, that we ensure compliance, efficiency, and accountability to not only our consumers, but also our stakeholders at large. By detecting our fraud, waste, and abuse within the program and within the network, as well as to make sure that those dollars that they're spent appropriately, and that they're paid appropriately to those providers in our network, and we ensure that those we ensure that happens by recouping incidents where those dollars are not appropriately paid out. Some of the actions that we take, again, just to elaborate a little bit, we eliminate and recover improper payments. But if you see in the third tier down, we we also educate our providers on those Medicaid program integrity issues. Now, some of these issues could be statewide. Some of these issues could be regional, and more than likely, a lot of it is nationally as well. So we try our best to keep abreast of what's going on, not only within our own catchment area, but also the trends that are happening nationally. So as we learn these things, we also share them in our network as well. Now, the first part to developing your client's toolbox is to be aware of those provider bulletins. Now, we get those quite frequently, and Provider Network does a very good job of providing timely information as they receive it, and also some things that are listed within those bulletins are things that are coming down the pipe. So as Jeff Lackey stated earlier, some of the things that are to be ready for, such as EHR and some of the things with the waivers, that information is timely. So in preparation for those changes to come, gives you a leg up, if you will, in adjusting whatever compliance tools that you may have internally, and also to amend some of your processes therein. There's also some adjustments to definitions that are listed within these bulletins as well, some things that you want to be aware of. Also, the trainings that are presented through Partners Training Academy. A lot of them are very well put together and presented. Also, that they're timely. I think recently we had one on peer support, so we've had some on med management, we had some on a variety of different topics, and also by request as well. So again, valuable information that comes through these bulletins, as well as reminders regarding documentation, as I think we just had this month, regarding documentation and claim submission. So please pay close attention to those provider bulletins. They provide pertinent information and timely information as well. A biggie, but a simple one at best. Clinical policy definitions that dictate how you provide services for consumers. Some of these change year to year, quite a bit of them do, but these also coincide with other statutes and regulations that are cited within those policies as well. They're not always inclusive of what is required, so keep that in mind when you are looking at these policies. As they change from year to year, some requirements are no longer needed and some requirements are added. And these could be a difference of, it could be a big difference in how, if in any way that you identify an overpayment, whether one would be cited as a payback or one that isn't. So it's very important that you keep up to date with the policy changes from year to year, or if the service definition that you're actually providing, whether or not it changes or not. Be familiar with your definition. Quite frequently, we've come across some providers that provide a service, but not quite, not quite up to par with regard to what their service requires. And you go back to the clinical definition, some of the requirements are not being met, and that results in a payback. So it's it goes back to keeping up to date, being aware of the changes that happen with the definition of the services that you provide. And also with regard to that, annually, there is I can't think of the proper term that state uses, but there's a time period when they take requests. They open up a definition, time for input regard to the definition. So there's a time to give your input to the state to make changes that you see, and I mean practical changes that you may see that may be needed to be able to provide this service in a much more practical and much more efficient way, and that will also more importantly benefit the consumers that you serve. Records and Documentation Manual, APSM 45-2. Um, can't say this enough. Be very familiar with this manual. It's descriptive of the required components of the clinical records for whatever service you may provide. It also delineates different requirements for different record keeping for your particular service. It also gives detailed lists of components of a clinical note for those services as well. It also has a rate index and indexes that give you suggestions, some things that you could use to build out your clinical note for whatever service you're providing. Now, you also see that this manual often overlaps and it also is referred to within the respective clinical coverage policy of the service that you might be providing. So that's one other thing to keep in mind when you're reading your CCAs, your clinical coverage policy, CCPs, and that they are referred to often. They refer to often the manual. So be very familiar with this, and also keep in mind that there's some other changes that are coming, that are upcoming with this manual as well. Some other tools. Last but not least, the provider manual is updated annually. It has valuable information that will keep you up abreast of requirements that partners has, or also the requirements of the state and federal guidelines as well. If you do not already have one, I encourage you to develop an internal compliance plan or program within your respective agency. It's imperative that you routinely, through this program, do your own regular self audits. Often you can save yourself a lot of trouble by doing self audits. You're able to catch internal control issues that you may be having that otherwise maybe a year or two go down the road and catch wind of it, or we come across of it in an investigation, and then that results in a payback. So do yourself audit. Do yourself a favor and do yourself some self audits and have your regular compliance plan as well. Utilize your provider network specialist. There's many questions that you come across, and that they are more than able to assist you with answering those questions that you may have in regards to being compliant with a requirement that you may see in a manual or a policy or whatever it may be. That's what they're there for. They're good at what they do. Last but not least, if you haven't already, sign up for alerts via the email with the Department of Health and Human Services. I think they've changed their name since then. DBA or DHB, I'm sorry. But sign up for those alerts, and as any changes come down the pipe, you're aware of them, and you're able to pivot if need be, or make some changes to your compliance program to be ready for those changes to come forward. Thank you for your time, and hopefully that was helpful.
Thank you so much, Mike. We appreciate that. And now we're going to hear from Kim about provider monitoring and 24-hour coverage.
Thank you, Rowena. As Mike mentioned, I've provided some information at the end of this section of the PowerPoint for some helpful links. The records management and documentation manual is one of those tools that you can use to assist when referring to requirements specific to the clinical coverage policy, which is HC 7.4, indicating that all enrolled providers are responsible for ensuring access to 24-hour crisis for consumers that are served. And that may be done in ways that are face-to-face, contracts with other providers who are assisting with 24-hour coverage, or telephonically. So we're going to talk about some specific ways that can occur for the convenience of both you as a provider, but also for the consumers that you serve and for people in the community who are involved with our consumers in a crisis situation. So it's important that you be aware that this is a requirement that must be documented. So you must make a copy for yourself, also have a copy provided for your consumers. And if there are patterns of clinically documented crisis that may be occurring historically, or if there are instances where your consumers have indicators that a crisis could occur, then you would need to be aware of that and update your crisis coverage plan. So HC 7.4 requires that your crisis coverage specify weeknights, weekends, any instances of vacation that you may take, or any instances of unplanned occurrences for you, especially if you're the only one providing services in your office. And so sometimes there may be instances where there are unplanned absences or extended times that is away for consumer access. So it's important that your consumers, as I mentioned earlier, be informed in writing. And I'm going to give you an example in a later slide of a form that I found. Some providers have indicated previously to partners that this particular element of demonstrating a document that shows coverage as being provided has been an area of difficulty in the past. So I was able to find a fairly universal form that hopefully will help you guys, and that you'll be able to tailor to your own practice as needed. It's important that if you have someone in your office who provides backup crisis coverage other than yourself, that you provide all the current contact information for both you as well as any backup providers that you're contracted with, or who also may be in your office that you are asking your consumers to work with regards to after hours or weekend coverage or unplanned absences. It's important per this policy to demonstrate documentation in a written format that differentiates between medical and behavioral health crisis emergencies. For example, if you have a consumer who has documented medical crisis that may overlap with behavioral crisis and may trigger the other, or vice versa, it's important that your clients are educated with regards to the differences, for example, of when to call 911 versus when to utilize your crisis coverage policy for behavioral health, because you as the provider are responsible for that behavioral health management piece. But if there are medication issues or medical issues that might complicate a crisis event, that would be important to let your consumer know that they need to utilize those medical options as well. All right, so just to familiarize yourself, once again, sometimes it's good to go back to the basics of what a crisis is. It's important for the purposes of this slide, to just be aware, as you all are, that the perception of a crisis, or the feeling of the inability to cope with a situation or event, is often more, important than the actual, it's, sometimes that's not applicable, but sometimes the perception, of the person's disequilibrium or the inability to cope, may supersede, an actual, event that has occurred. So it's important when you, have an awareness clinically of your client, a history, a good history in place, that, you educate your client on things to do, to decrease or de-escalate a crisis before it occurs, all based on the information that you know, because you know most, accurately, the needs of your clients. Some emergent situations are, and this is per, the definition here, is, that you have a moderate or severe, risk of safety, based on the need for supervision, okay? And so that has to do, with independent, functioning versus the need for supervision, and sometimes the crisis may occur when there's a lack of supervision, when that is needed, so that could, instigate a crisis. Second is a moderate or severe risk of substance, abuse withdrawal. It's important to be aware for all these, we'll talk about this in the next couple of slides, to, stay current with your HIPAA, regulations regarding, crisis events and how to notify people outside of your agency, regarding HIPAA, but specifically to substance use disorder diagnosis, you'll need to be aware of the 42 CFR, requirements as well to protect, the privacy of your consumers. The third is a mild, moderate, or severe risk of harm to self or others. And then lastly, you have, an instance that may occur, regarding a severe, interference with a physical, cognitive, or behavioral functioning specific to a consumer's mental health diagnosis. And so as you begin to evaluate whether it is in the initial phases of your service to your consumers, or whether you're reviewing a crisis plan and updating information based on, something that has occurred, recently or historically over the past year, if you're doing an annual review, you're going to make sure that you document in your assessments none, mild, moderate, or severe for those four, previous, components of a crisis, situation. You're going to make, sure that you, adhere to the cultural, needs of the clients that you serve. Again, because you know them best, when you provide information to collateral entities who may assist in a crisis, the more information that you can provide, specific to needs, language barriers might be an obvious one, but also personal preferences that are specific to the cultural background, for your clients. Make sure, to assist in the respect that he or she receives, in the process of going through all of the elements of the crisis situation from beginning to end. And then make sure that everything that you do is specific to the trauma that is, that your consumer might experience. Sometimes crisis plans, become plans that, look very similar from client to client. And, sometimes that is not helpful, for people who don't have an awareness of the consumers, being served from provider to provider. So the more information that you can provide, the more, assistance, and ease of assistance it will provide to people who are working with the client when you're not able to. A couple of things to be aware of with regards to high-risk criteria. You're gonna want to be aware of missed appointments. Sometimes, again, that sounds like something that is obvious, but it's often sometimes, things that are easily overlooked. as the day gets busy or, staff aren't available within the office setting, to sort of track those patterns. If there's no alert system internally for a certain number of missed appointments, and sometimes that's an easily overlooked area, which is something that will assist you in identifying a potential crisis, whether that one could occur or that one has occurred. It's important to be aware that hospitalization is a vulnerable point, hospitalization for consumers, so that when they are discharged from a hospital for either a mental health crisis or a crisis that they may experience, that they have an appointment with you, and that happens really quickly so that you can get that consumer engaged back in services that he or she needs. So a couple of resources that you can utilize as you develop your crisis plan or as you review and revise your crisis plan. The individual, sometimes I've seen that the individual, if they have specific references to ways that they prefer to de-escalate, it assists a crisis in not occurring, or it slows the process down so that they have a little more control in the timing of a crisis situation. So the individual is him or herself a resource in the crisis plan, as well as the legally appointed guardian, if that's applicable to the situation. The service providers, especially if there's more than one. If you are the primary provider, then you're responsible for the crisis plan in full. Sometimes you may have the ability to draw in support from other providers providing different services for the client. If there's a team or if there's a particular program, that will also be beneficial. And sometimes it's helpful, like to law enforcement or the LME-MCO, with regards to who to call for resources as the consumer works through the process of the crisis. You're going to have different emergency department personnel positions, as well as law enforcement. So the client may identify personal supports that are part of his or her crisis plan, and that's important as well. Again, just reminding you to provide this. I'll talk at the end about the LME-MCO expectations with regard to uploading, but it's also helpful if the consumer takes their crisis plan to the hospital with them, so that all of that information is there. So this brings us to the sample document that several providers have asked for, and it's on the PowerPoint that you'll be able to access, so that you can tailor this to what your agency needs in the best way. Also, you can expand this to differentiate if there are applicable medical situations or circumstances that apply, or anything that may be applicable outside of the plan itself. It's important also not to document and discuss the crisis plan during a crisis, right? The best time to do this is when your consumer has less stress or is feeling their best. And so this is something that you're going to want to be a working document, your crisis plan. It's not something that you do at the beginning and forget until next year's update. There is nothing more frustrating for emergency services to call all of the phone numbers on a crisis plan and have them be disconnected. And so it's just important to make sure that you stay current there. I'm not going to read all of the elements of the 6 steps to writing a crisis plan. For most of you, this is routine, but sometimes it's good just to stay current and to remember to update information. This particular policy hasn't been updated recently, but it has been updated with some elements that providers have indicated have been difficult to incorporate into their practices. So just be aware of some of the components as you develop your crisis plans. It's important that you have very current identifying information, obviously the initial date of the crisis plan, but also all of the identifying information for your client, their current address, all of the information that applies to them as a mental health consumer, and any information that may be applicable with regard to either more than one diagnosis or medical diagnosis as well as a mental health diagnosis. So you want to identify the supports for your clients, and then also internally, you're going to want to make sure that you have a clear outline of a follow-up plan so that you as a provider know what to do in the event that a crisis has occurred, and so that transition is smooth. Obviously, you would want to have an appointment available. But if there are teams or other program participants that are involved with that consumer, you're going to want to pull those teams together fairly quickly so that the engagement continues with regards to service. You're going to want to make sure that you attach current documents. Especially this is true if there's a hospitalization or an EMS response. You're going to want to make sure that any type of living will, any healthcare power of attorney, advanced instructions, any type of RAP plan, behavior plan, or any type of suicide prevention plan are available for those who may be involved collaterally with in the event of a crisis. For step 6, on looking at general characteristics, you're going to want to talk with your client about what a good day looks like, what has worked in the past. You're going to want to be very specific in your crisis plan as you develop ways to reduce or avoid or de-escalate a crisis from occurring. And as I said earlier, the more information that you can provide to external collaterals involved with your client, the better able everyone will be able to address the crisis that your client may be experiencing. You're going to want to make sure that the options go from least restrictive to most restrictive, depending on multiple factors of applicability as far as the consumer and diagnosis and what that looks like. But you're going to want to be sure that everything is specific to the level of behavior, the diagnosis of your consumer, so that a plan doesn't lack a reflection of what is most applicable to your client. So again, we want to look at what's working and what's not. The consumer is going to drive his or her preferences with regards to what happens in a crisis. Both you and they are the biggest and best resources for people who don't have a history or a knowledge of the consumers that you serve. And so we need your help through this crisis plan to help us understand what works best based on the consumer's preferences for all of those steps during a crisis situation. Sometimes that is specific to treatment facilities. Sometimes that includes medications that have or have not worked in the past. And sometimes it also needs to include allergies. Obviously, that's a medical, primarily a medical component, but we want to make sure, for the mental health, especially if they're taking a medication that's specific to a mental health diagnosis, you update that. You need to be very specific, when addressing de-escalation, based on what works best for your client, and also, what works best in multiple settings. If the client is in a setting that may increase, then he or she can begin to, utilize the crisis plan, on their own. These are things that you can do in a clinical setting that can be applied outside, from a session, but in a way that gives them, empowers them to take control of the situation before it escalates. So the expectations of partners, as an LME-MCO, we want to make sure that, the one crisis plan, is part of their person-centered plan, that, is uploaded, in Alpha, and, that is not just an annual update, but that's something that can, occur, after a crisis. Again, make sure that you, get your separate documentation from the slide, because, you will do that in addition to the PCP, and make sure that your client gets a copy. It's a standalone document, again, that's uploaded into Alpha, and that will assist the MCO, which is a resource when you're in a crisis situation for your consumers, to dispatch mobile crisis, or other, emergency response, systems that may be needed. And the last slide is your references, and you can use, the PDF or the, records management documentation manual, as well as the policy. Be sure to post any questions that you have, and we will answer those.
Thank you so much, Kim. We appreciate that. I'm going to talk very briefly about our network development plan and our quarterly progress for the first quarter. I want you to know just a few things. I'm not going to go over all the slides because we're running out of time, and I really want you to hear from Lisa Jordan in performance monitoring. So, since this is going to be posted on the website, you can refer back to those slides and look at them in detail. So, what I want you to know as a takeaway is that because the needs assessment was done, so close, we added some of our goals in September to the plan. So our progress is only at about 15% with our first quarter report. And just so you know how this works, our cross-function team takes on the brunt of getting our work done to implement our network development plan. And that group is divided into 4 main work groups. We have our prevention and education group, quality monitoring and management, social determinant group, and our treatment group. Now, our treatment group has subcategories. You can see that listed under there. Those are all work groups as well. So they take on the heavy lifting and get all of the main work done to implementing services and pushing those work plan initiatives through. So you can see from the next few slides, these are an example, and these are just some highlights that we put on here of some of the goals. And so, like I said, in the name of time, I'm not going to go through all of these because I really want you to hear from performance monitoring because that's much more impactful and meaningful for you. So I'm just kind of breeze through these real quick. I do want you to see that, for example, some of our goals are to promote community awareness and behavioral health services in certain areas. And you can see that some of the steps that we take to do that, to promote awareness of behavioral health stigma, and then some of the things that we did. So you can kind of get an idea at how that ties to that particular work group. And then under quality management, so for example, the first goal is to get a certain number of providers connected through Health Connect. And that's why you see we're doing such a blast of communication to all of our providers about Health Connect to make sure that you guys are hearing about it and getting connected. You can see some of these other goals for quality monitoring and management. Um, so under social determinants, again, I'm just going to go over a quick highlight and pick one out. Like for example, goal number 3, coordinating at least one workforce summit in Gaston County by 6/30/19 to educate local businesses about hiring people. And they did meet with the Gaston Chamber of Workforce Development and discuss processing services, key businesses and the benefits of hiring those with disabilities, and identifying possible businesses for employment summit. These are just an example and a highlight of some of the work that's being done in these work groups. So under the treatment group, this is a very large group. This is really where a lot of work is done, the network development plan. So a lot of work, they have a lot of goals, a lot of work is done here. These are just a very few goals. I'm not going to go over all of this. But this is where you see like a lot of your treatment residential services. You'll see a lot of these listed under here. You'll see things for facilities, for all kinds of services to be implemented. You'll see things like that under their work group. And that particular work group was exceptional in the past quarter with getting things done. Now, what I do want to go ahead and say again, like when we get to this particular slide, is that, again, for the first quarter, we're lower than 25% because we added a whole bunch of those goals after the needs assessment, so we implemented them in September. So we've got a little bit of progress that we're making at this point in time, and so our second quarter goals, you'll see, will be a lot higher. If you have any questions, you're welcome to get in touch with me and with your questions directly to me or through partnersbhm.org as well. And now I'm going to turn it over for performance monitoring, and we'll hear from Lisa about that because I know that directly impacts you guys. What do you want to tell us?
All right. So last but not least, we will discuss the provider performance reporting. This initiative is directly related to partner strategic planning goals to improve our provider performance. We have a goal to develop policy and procedure regarding provider performance, reporting, and also publishing. We also have a goal to establish metrics that will tie payment, value, and/or quality to the utilization of 4 main categories. These are quality, resource use, clinical practice, and advancing care information. So my overall goal in delivering this presentation to you guys today is to explain exactly how we will review and score each of you during your annual performance review. Last year, you may remember working with your account specialist as they completed your annual performance review. This year, although the performance measures are basically the same, we are scoring them just a little differently. And so, as you can see on the slide, the composite performance scores will factor in performance in the 4 weighted performance categories on a 0 to 100-point scale. Basically, your quality score plus your resource score plus your clinical practice score plus your promoting interoperability / advancing care score equal your total performance score. And so, as this is the first year that we're rolling this out, this is our performance categories and proposed weights. So the resource use will be 10% of your score. Promoting interoperability, formerly known as advancing care, will be 25% of your score. Clinical practice improvement activities will be 15% of your score. And our largest category, which is quality, will be 50% of your score. So how is each measure scored? All right, so in each category, there will be specific performance measures. If the measure is met, you'll get 1 point. It's a pretty simple system. If the measure is not met, then you will get no point for that measure. However, and as we're going through these later slides, if you hear something that does not apply to you because you are a LIP or a group practice, if the measure does not apply to you at all, and we have designated those, and we are aware of which categories apply to certain providers. If the measure does not apply to you, you still get a point because it's through no fault of your own that you are not meeting this measure because it does not apply to you. All right, so what does that look like? We have 9 quality measures at a weight of 5.55 points each. We have 3 promoting interoperability, advancing care measures, which are at 8.33 points each. We have 5 clinical practice improvement measures, which are 3 points each. And we have 3 performance measures, which are at 3.33 points. All right, so after the annual performance review is completed by your account specialist, they will return those results to me. I will collaborate those scores. I will return those back to the account specialist, and they will make your performance score available to you. And you'll have an opportunity for input. You'll see each measure, you'll see each score, you'll see all of the comments that are pertinent to your organization. After a 30-day review of your performance score, if we have received no comments, then partners will, once we get to the end of this fiscal year, we'll begin to publish provider performance scores. All right, and so we won't go through all of these because we are already limited with time, but what I will let you know is that each of the performance measures within the next category, so there's the 9 quality, performance measures, and we will make these available to you if through the email, so that you're able, and you'll also be able to see them on the webinar just to look at them. So all of the quality performance measures are listed there, and then we have the promoting interoperability. Those 3 are listed next. We have our clinical practice improvement. Those 5 follow. And last but not least, we have our resource use, and those 3 performance measures are listed there. Again, I know that these you guys did this annual performance review last year, and I do want to repeat that most of the performance measures are the same as they were last year. We will be scoring them differently. I'm sure that there will be questions or comments and suggestions, so if you have any, please don't hesitate to return those responses to questions@partnerschm.org, and I thank you for your time and attention today.
Thank you so much, everyone, for participating today in our LIP collaborative webinar. We did run a little bit over. I apologize for that, but I appreciate you hanging in there with us. We did have a packed agenda today. I do also want to mention that we will be adding to our LIP website page those clinicians or LIPs that wanted to post their contact information to form like a directory, so to speak. We are working on that, so that's under development, and I just wanted to give a quick update on that. So that is in development and will be done. So in a couple days, this webinar will be posted and added to the website, and so you'll be able to access it. So you can go back and see the slides that we had to rush through. So I apologize for that, but it is there for your viewing pleasure later on when you need to access it again. So we do appreciate your time and attention, and I also appreciate those that have reached out to ask questions and ask for resources and suggestions for topics and things that they're interested in. That's always very, very helpful. So please continue to do that. That makes these webinars much more beneficial for you all. So please continue to do that. So y'all have a wonderful day, and we will talk again at the next one. Thank you very much.